Hello everyone, welcome to Pharmacological channel. Today I'm going to talk about the pharmacology of antiplatelets. So let's see how antiplatelets work. So first of all, as you can see here, once you have vascular injury, like the wound or you get cut, so you got like a leakage of the vessel, the damage of the vessel, platelets will come in contact with the leakage site of the vessel. On platelets will have so many receptors that can bind with the subendothelial matrix, for example, the collagen, or even the von Willebrand factor, which normally it circulates in the blood vessel. But once the vessel gets injured, the von Willebrand factor could bind with collagen and then act as a ligand for the glycoprotein 1b95 complex, leads to platelet adhesion to the injured site. And then once these receptors bind to the ligand, like a collagen, it will activate platelets. So you can see the platelets will release these secondary mediators like a ADP or thromboxane A2, which could then further activate the platelets, what we call amplification phase. And also the glycoprotein to be 3A, which normally it couldn't bind with a fibrinogen, but once platelet gets activated, the glycoprotein to be 3A will undergo a conformational change and it could bind with the fibrinogen, and fibrinogen will act as a bridge to link platelets together and then leading to a platelet aggregation at the injured site. Also, the coagulation cascade will occur together with the platelet aggregation to form a firm and stable clot formation to stop bleeding. But in case like ischemic events like myocardial infarction or ischemic stroke, this process is all activated, so it leads to a thrombosis that block the flow of the blood to the tissue, leading to the sign and symptom of myocardial infarction like angina, for example, or the symptoms of ischemic stroke as a consequence of these over activation of the platelet aggregation and coagulation cascade. So today we will talk about the drug that will inhibit platelet activation and aggregation to treat that ischemic event. Nowadays, the antiplatelets can be classified into 5 groups. The first one is cyclooxygenase 1 inhibitors or COX-1 inhibitors, and the second one is the ATP receptor antagonists, or what we call P2Y12 antagonists or blockers. And the third group is a glycoprotein 2B3A or integrin alpha 2B BU3 antagonists. The fourth group is phosphodiesterase inhibitors, and the last one is thrombin receptor antagonists or PAR1 antagonists. First, we're looking at the COX-1 inhibitors, the drug that could block the COX-1 enzyme in the platelets are aspirin and trifosol. We'll focus on aspirin today. If you look at this platelet, once the platelet gets activated, the arachidonic acid here, which normally it's anchored to the membrane, but once platelet gets activated, the enzyme phospholipase A2 will cleave these arachidonic acid into a free arachidonic acid in the cytosol, and then the cyclooxygenase 1 or COX-1 enzyme will convert arachidonic acid into a thromboxane A2 and then release from these activated platelets. Thromboxane A2 is the secondary mediators to bind to its receptor on platelets itself, so it further activates the platelets, what we call the amplification process. If the drug could block the COX-1 enzyme here, so you inhibit the synthesis of thromboxane A2, you inhibit the activation of platelets. For aspirin, this is a very old drug. We know it a long time ago. So aspirin could produce a rapid inhibition of a platelet COX-1 at a pre-systemic state. However, this drug has a short plasma half-life, which is about 15 to 30 minutes. But aspirin inhibits COX-1 in an irreversible manner, so it's block COX-1 throughout the lifespan of the platelets, which is about 7 to 10 days. However, normally in every day, the new platelets will be synthesized like about 10 to 15%. This is the reason why we need to take aspirin every day to inhibit newly synthesized platelets as well. So talking about the adverse effects of the aspirin, so as we know that the COX enzyme could produce either a beneficial effect or a detrimental effect. In the GI mucosa, the COX-1 enzyme will produce the prostaglandin E2, which has a gastroprotective role by inducing the mucus secretion, increasing bicarbonate production, and also increase mucosal blood flow. But aspirin that irreversibly block COX-1, so it blocks the synthesis of PGE2 by the GI mucosa, so it increases the risk of peptic ulcer or GI bleeding as the adverse reaction caused by aspirin. Aspirin also have a local irritating effect since it is a weak acid, so it can produce a local irritation in the GI tract as well. So in terms of a antiplatelet activity, it blocks COX-1 enzyme in the platelets, so it reduces the production or synthesis of thromboxane A2, but it also increases the bleeding risk as well, since the platelets become less activated by the action of aspirin. The next one is P2Y12 inhibitors or P2Y12 antagonists. So if you look at here, you'll see that the ATP could bind with the P2Y12 receptor and then leading to the inhibition of adenylate cyclase enzyme. The ATP cannot be converted to the cyclic AMP, so once the cyclic AMP is reduced, so the platelet is become easier activated. So the P2Y12 antagonists that block the P2Y12 receptor, so ADP could not bind or activate this receptor. So the cyclic AMP could not be reduced, so platelets will stay in a resting state. This is the mechanism of action of P2Y12 antagonists. The cyclic AMP maintain the resting state of the platelet, whereas calcium, if you have high calcium, it will trigger the activation. It acts in an opposite way as a cyclic AMP. So the properties of the P2Y12 antagonist could be divided into two groups. The first one is the thienopyridine groups, which act as a prodrug. So by itself, these drugs could not inhibit P2Y12, but once it is converted to an active metabolite, it could inhibit a P2Y12 receptor. So this is what we call a prodrug. But all of these drugs are irreversible P2Y12 inhibitors. It means that these, once it's converted to the active metabolite, it will bind and inhibit P2Y12 irreversibly. So these drugs include ticlopidine, clopidogrel, and prasugrel. So you can see that ticlopidine will need a two-step of cytochrome P450 metabolism to get an active metabolite for P2Y12 inhibition. The same as clopidogrel. Clopidogrel, about 85%, will be metabolized by esterase enzyme and will become inactive. Only 15% of these drugs will become an intermediate following esterase metabolism, and then this intermediate will undergo two steps of cytochrome P450 enzyme metabolism as well, particularly CYP2C19, and then got the active metabolite for P2Y12 inhibition. But for prasugrel, you can see here, prasugrel could not be destroyed by esterase. Prasugrel is metabolized by esterase to get an intermediate, which is different from clopidogrel. So esterase cannot destroy prasugrel, but it just changed prasugrel into an intermediate. And prasugrel, once it get into an intermediate, it undergoes only a single step of CYP metabolism to get active metabolite, which is different from ticlopidine and clopidogrel, which require a two-step of CYP metabolism to get the active metabolite. But for the other group, which is a direct P2Y12 inhibitors, including ticagrelor and cangrelor, these two drugs don't need a activation process, so it acts as an active P2Y12 inhibitors itself. But these two drugs act in a reversible manner, so which is different from ticlopidine, clopidogrel, and prasugrel. First, we're looking at the ticlopidine. This is the first thienopyridine, and it shows about 40 to 50% inhibition of platelet aggregation induced by ADP. So using a normal dose like a 250 milligram twice daily, it takes 3 to 7 days to reach these 40 to 50% of platelet inhibition. And also it has a distinctive pharmacokinetic properties. It has a non-linear pharmacokinetics. Initially, the half-life would be about 12 hours, but when you use for long term, the half-life will become longer, like many days. And the common ADRs of the ticlopidine will be GI side effects like nausea, vomiting, and diarrhea. But what I want to mention or emphasize here is a serious adverse drug reactions from ticlopidine, which is a reversible type of ADR. So it resolves once you stop taking the drug, but it's quite serious. These include neutropenia, aplastic anemia, thrombotic thrombocytopenic purpura or TTP, and also elevated liver enzyme. So you can see here, ticlopidine causes blood dyscrasias and also increase the liver enzymes level. For clopidogrel, it inhibits 40 to 50% of platelet aggregation induced by ADP in a similar manner as a ticlopidine. Once we use a loading dose like 300 to 600 milligram, it will take like 2 hours to reach this effect. But once you use a normal dose like a single 75 milligram tablet once daily, it would take like 3 to 7 days to reach this effect, the same as ticlopidine. But the important thing for clopidogrel is it needs cytochrome P450 isozyme 2C19, as I mentioned in the previous slide. So once the patient has CYP2C19 polymorphisms, which reduce the enzyme activity, so like poor metabolizers or slow metabolizers, for example, like the one that will have like a gene CYP2C19 star 2 or star 3, which leads to a reduced enzyme activity. These patients will got a low level of active metabolite of clopidogrel, leading to a reduced antiplatelet activity. And in a similar manner, for the drug that could inhibit CYP2C19 like omeprazole and esomeprazole, which could inhibit or block CYP2C19, leading to a reduction in the conversion of clopidogrel into an active metabolite. So it may reduce antiplatelet activity of clopidogrel. However, clinically, we didn't see ischemic event in patients due to these drug interaction. But in terms of antiplatelet activity, these drugs could reduce the antiplatelet activity of clopidogrel in vitro. And the ADRs of clopidogrel, it induce lower bleeding risk than aspirin, mainly the GI bleeding, and it's also show a lower blood dyscrasia than ticlopidine. So nowadays, clopidogrel will be more popular than ticlopidine since it has a lower blood dyscrasia events compared to ticlopidine. The next one is prasugrel. This drug is more potent and more rapid action than clopidogrel. So you can see here it inhibits about 70 to 80% of platelet aggregation induced by ADP, and this effect could be reached by a loading dose within 2 hours, and you could see a significant effect at 30 minutes after administration. And the important ADRs of prasugrel is the higher bleeding risk than clopidogrel. This is very important because this drug is contraindicated in patients with prior stroke or a transient ischemic attack or TIA, or the patients older than 75 years, since it increased the risk of bleeding in these patients. But in terms of blood dyscrasia, including TTP, the incidence is lower than ticlopidine, which is a better safety profile than ticlopidine. And the next one is ticagrelor, which is a direct inhibitor and act as a reversible antagonist. So this drug is also more potent and more rapid action than clopidogrel, and it inhibits about 80 to 90% of platelet aggregation induced by ADP, and this effect could be achieved by a loading dose within 2 hours, and this significant effect could be seen at 30 minutes after administration as well. And the important pharmacological properties of ticagrelor is it acts as a non-competitive reversible P2Y12 inhibitor. So it possibly binds at allosteric site, the different site of ADP, or it may act as inverse agonist on P2Y12 receptor. And ticagrelor could also inhibit the reuptake of adenosine, which also involves the antiplatelet activity of ticagrelor. This drug is metabolized by CYP3A4 mainly, and the unique adverse drug reaction of the ticagrelor is dyspnea, difficulty of breathing, dizziness, and headache, which could be due to an increase in adenosine level by its mechanism of action. And for bleeding risk, it is the same as clopidogrel, partly because it acts as a reversible inhibitor, so it's not a prolonged effect as prasugrel. And the last one is cangrelor. Cangrelor is the injectable drug in this group. The structure of cangrelor is an ATP analog. It acts as competitive reversible inhibitor on P2Y12 receptor. And the important property of this drug is it is more potent and more rapid action compared with clopidogrel. So it almost completely inhibits platelet aggregation induced by ADP, particularly using the loading dose. It takes less than 5 minutes to achieve this effect. So this drug is metabolized by dephosphorylation, and it has very short half-life, like less than 10 minutes, and the duration of antiplatelet action is about 1 to 2 hours. It may be used for a bridging therapy. For the bleeding risk, it has a bleeding risk similar to clopidogrel. So this table summarizes the pharmacological properties of P2Y12 inhibitors. As you can see, clopidogrel could inhibit 40 to 50% of platelet aggregation, whereas prasugrel is more potent than clopidogrel because it inhibits 70 or 80% of platelet aggregation, and ticagrelor and cangrelor as well. They are more potent than clopidogrel, as you can see from this table. And in terms of irreversibility for P2Y12 receptor binding, for clopidogrel and prasugrel, and also taclopidine, they are all irreversible inhibitors, whereas ticagrelor and cangrelor, they are reversible inhibitors. And you can see the reversible inhibitors, you have to take the drug more frequently, like twice a day, or like intravenous infusion, for example. And the duration of action for the reversible inhibitor is shorter than irreversible inhibitors. This is the key pharmacological properties of the P2Y12 antagonist. So the next group is a GP2B3A antagonist. So normally, as I mentioned, GP2B3A on resting platelets could not bind fibrinogen, but once the platelets gets activated, the glycoprotein 2B3A will undergo a conformational change and could bind with fibrinogen and promote platelet aggregation. However, when you use the GP2B3 antagonist, it could not inhibit platelet signaling inside the cell. So these drugs will mainly used as adjunct therapy, particularly in an acute setting. So there are three drugs at the moment. The first one is abscesimab. So abscesimab is a fragment of humanized chimeric monoclonal antibody. It has the same sequence on fibrinogen, so it helps binding with the glycoprotein 2B3A on platelets, and also abscesimab act as a steric hindrance because abscesimab is a large molecule. So once it binds on platelets, so its structure will form a steric hindrance to block the binding of fibrinogen to GP2B3A. So, but abscesimab itself not competitively bind to GP2B3A. Since it is a humanized chimeric monoclonal antibody, abscesimab could produce hypersensitivity reaction, whereas eptifibatide and tirofiban, they are a small molecule. They competitively bind to GP2B3A, which then inhibits platelet aggregation. The next one is phosphodiesterase inhibitors or PD inhibitor. For the phosphodiesterase enzymes, the PD3 will function to degrade the cyclic AMP, such as in platelets, but for the PD5 isocymes, it will degrade the cyclic GMP, such as in the vascular smooth muscle cells. So in this figure, you can see that the PD enzyme will degrade the cyclic AMP into 5' AMP, and once you use PD inhibitors, you block the degradation of cyclic AMP and keeping the platelet in a resting state, since you increase the cyclic AMP level. For the PD inhibitors, there are two drugs at the moment, which are dipyridamole and cilostazol. For dipyridamole, it inhibits both PD3 and PDE5. Dipyridamole also inhibits the reuptake of adenosine, and these two mechanisms could contribute to antiplatelet and vasodilatory effects of dipyridamole. And this drug is metabolized mainly by phase 2 metabolism, which is a glucuronidation. It has half-life of 10 hours. The common adverse drug reaction is headache, particularly at the beginning of using the drug. For cilostazol, it is a potent PD3 inhibitor. It also inhibits reuptake of adenosine, as the same as dipyridamole. So these mechanisms contribute to antiplatelet and vasodilatory effects of cilostazol. Cilostazol is metabolized by CYP3A5 and has a half-life of about 10 hours as well. The adverse drug reactions of cilostazol includes headache, loose stool, and palpitation. Cilostazol and dipridamole are commonly indicated in the ischemic stroke, but cilostazol is also used to treat the intermittent claudication in peripheral artery disease. The last group is PAR1 antagonist. So PAR is a protease activated receptor, which is a thrombin receptor. There are PAR1 and PAR4. So on platelets, PAR1 will mediate platelet activation at the low concentration of thrombin, whereas PAR4 require a higher concentration of thrombin. So PAR1 is a good target for a drug candidate. And if PAR1 antagonists block PAR1 receptor on platelets, so thrombin could not bind and activate PAR1, then the platelet could not be activated. So the only drug that has been approved nowadays is Vorapaxa, which is a reversible PAR1 antagonist. It slowly dissociates from PAR1 receptor, and it inhibits about 80% of platelet aggregation induced by thrombin, and it reached these effects at about 2 hours. And Vorapaxa is metabolized by CYP3A4, and it has a very long half-life, about 150 to 300 hours. Vorapaxa is currently approved by the US FDA, but not as the first-line drug, for a secondary prevention in patients with prior myocardial infarction and peripheral artery disease. And this drug is contraindicated in patients with prior stroke since it increases risk of bleeding. This is all about the pharmacology of antiplatelets. I hope you enjoyed the lesson from Pharmaco OK, and see you in the next lesson. Thank you very much.